Hello, a warm welcome to this webinar today from the gCMEp practice group on educational outcomes measurement. My name is Froukje Sosef and I'm the medical director and co-founder of Courtoet, a company in independent medical education. And as Courtoet, we are a proud member of the gCMEp practice group. During today's webinar, which is 30 minutes, we will provide you with an overview of the levels of outcomes, educational outcomes, and also give you practical examples on how these can be achieved, but also how these cannot be achieved. With me today are Monica Ghidinelli and Sophie Wilson. A lot of questions have already been submitted through the registration page. We categorize them and we'll go through those. But during the webinar, if you have any questions, we would like to ask you to post them either in the Q&A section or in the chat section, and we will do our best to go through all of these questions. So before we dive into the discussion, I would like to ask Monica and Sophie to introduce themselves. Ladies.
Hi, I'm Monica Ghidinelli and I work for the AEO Foundation. That is an organization that focuses on education, innovation and research for surgical treatment of trauma and musculoskeletal disorder. For the AEO Foundation, the outcome measure of our education is really important. And if you think that we have 14,000 faculty all over the world that teach to more or less 55,000 learners every year, they are the first one they want to know, okay, what the education that we provide is effective, is really improving patient outcome. So they want to know that their time that they volunteer is worth it. So this is why the AEO Foundation has been investing a lot of resources in this area. And I'm happy to share with you a few examples of what we are doing.
Thank you, Monica. Hello, I'm Sophie Wilson, Director of CME Services at International Medical Press, and we're part of the Nucleus Global group of companies and known as IMP for short. So IMP specializes in peer-reviewed independent medical education and accredited CME across a variety of therapy areas, and we are founding members of the gCME practice group. High quality independent education with measurable outcomes is key to our programs to ensure that they're appropriate for the audience and effective. Thank you. Looking forward to your questions.
Thank you, Monica and Sophie. So let's start. Maybe the first question is for you, Sophie. For everybody attending, could you give a short overview of the possible educational outcomes for programs in independent medical education?
Thank you, Froukje. Well, when looking at outcomes of an educational intervention, the most important thing is to ensure that the outcomes you set out to achieve are aligned with the learning gaps that you're trying to fill. And they need to be realistic. And I'm going to use that word a lot of times, realistic. So, for example, if you're trying to bridge a skills gap, providing a lot of information and data is not going to increase skills. It's not going to improve skills. So be realistic about the gap and about how you're trying to fill it. So what outcomes can we expect from independent medical education programs? Outcomes generally fall into 5 boxes: increasing physician knowledge, improving practical clinical skills, physician attitude and motivation, i.e. changing the behavior of physicians, and lastly, there's systems outcomes. And those are ones that we probably don't address, at least not as independent CME providers. That's really what happens in government institutions, in hospitals and so forth. So generally, outcomes are categorized using Moore's outcomes framework, or the pyramid. It's used to assess learning and evaluate activities. Levels 1 and 2 are about participation, satisfaction, i.e. have you sat through, are you happy, was the food nice, that sort of thing. Level 3 is about knowledge gain. So what do you know? What do you know how to do? But it's just knowledge. And then level 4 is about competence, i.e. being able to show how to do something, at least in an educational setting. And then level 5 is about doing, implementing what you've learned in day-to-day in your clinical practice. And then 6 and 7, which we'll only touch on probably today, are more about improving patient community health. And that's really what, in my view, happens in the hospitals. And sometimes our programs touch on it. But I think Monica's going to go through some of these outcome levels in a bit more detail. Thank you, Froukje.
Thanks, Sophie. So maybe I'll stick with you a little bit longer. So your word realistic. Could you also tell us a little bit more about sort of the realistic feasibility of these outcomes?
Yes, so realistic, well, increasing knowledge is very straightforward. If you organize a program, you can increase knowledge and you can measure that acquisition of knowledge by using a simple multiple choice question. For example, after the activity, you do a little test and people have learned something. That sort of outcome at that knowledge level 3 level is pretty straightforward. Can we improve skills and how do we measure it? Well, if an activity is set up properly, yes, I think you can. So, for example, if you've got communication skills, you can acquire those by having a live role play workshop. Might be a bit more difficult virtually. Practical skills can be acquired also in a case study sort of simulation exercise. And I think the AO Foundation do a lot of that in surgery, and Monica will touch on that. So I'll leave that for Monica. But you can learn skills and you can measure it. So as well as knowledge and skills, programs are frequently designed to change physicians' motivation and attitude. And here a successful outcome might be to change physician behavior. So for example, you might use role play to teach motivational interview techniques so that next time physicians are in front of a patient, they change how they do their clinical consult to use some of these skills. Measuring that is going to be much more difficult. So you can change it and get good outcomes. Measuring it we'll talk a bit about more later. The ultimate outcome is to improve care and outcomes for patients. And this is definitely possible and realistic. With increased knowledge, better skills, a better attitude, physicians will change how they run their day-to-day clinic. And we should believe that this should have a positive impact on patients. I hope that answers your question, Froukje.
Yeah, thank you, Sophie. So over to you, Monica. So let's zoom in a little bit more on level 4. How can we demonstrate improvement in competence? Can you give it, because we're now going into the practical examples, can you give an example on that?
So basically now level 4, we want to know, is the participants able to show how is doing something? So let's say in the ideal world, we should be able to look at the learner and observe how, observe in a setting, and this will be, the learner should be able to describe what they are going to do. Let's say we do a lot of practical so skill training, so they will describe how they are going to do something, and we can do that in a learning setting, and we have done it. So you need only to train, let's say, the faculty to score how they explain, and you still need a certain standard setting, okay, because you need to compare the different participants. So it's still time consuming and not so easy to do. But what you can also do is, on a bigger scale, and is more is easier to do is to have, for example, a written case, and then ask with the MCQ, so multiple choice question, what is the option that they will choose on how to do a certain procedure or something like that. So in a way, you are able to monitor if they are able to show how they are doing something. Of course, you can choose multiple choice question, and this is our preferred option because it's easier to analyze. But if you have faculty that are willing to go through open text answers, then go for it, because it's also a good way. But even in this case, you need a standardized way to assess this. So you can compare how they are answering before the intervention and after. And in this way, you have an idea if they improve their competence, let's say. But yeah, or the easiest way that is a little bit suboptimal, but if you have no resources and no time to do it in a better way, then ask the participants to self-report on their competence level. It's suboptimal, but it's still giving you an idea of their if they improved.
Thank you, Monica. So this was level 4. Then let's look at level 5, Monica. Can you also give an example on that one?
So level 5 is performance. So are they really able to apply what they learn, and now they improve their performance? I mean, even here we have the best scenario would be to go in the clinic, follow them, and have someone scoring what they are doing. Is this really possible? Yes, in some cases, but it's like a real effort to do that. So another way to do the same thing is probably to review the patient charts that you have on the hospital level. Or what we have done actually is a clinical trial per se. So we record the surgeries that someone is performing, and then we analyze those surgeries. But this requires, I mean, this is a clinical trial, so you need ethical approval and so on and so forth. So the time and the resources that you need to put into that is really huge. And this is an ongoing project, so it's not like 6 months, it's over years, because it's really demanding. But what you can do on a daily basis and is ask for the self-reported performance. So then you so what we do on a regular basis in all our courses is actually just after the learning activity, we ask the participants to describe 1 to 3 changes that they are intending to make in their own practice. And 3 months later, we go back with the same statements to every single participant, so they know what they wrote, and we ask them which one they implemented, and in how many patients they applied this. So we have also a little bit of a readout of how many patients have been affected and if they implemented what they have learned. Also in this case is not a direct measure, but is what you can do on a daily basis, I would say.
Thanks, Monica. Very clear. So those were practical examples. Now, quite a few of the questions that came in, and that's for you, Sophie, is linking educational needs to educational outcomes. We all set up independent medical education programs. It starts with defining the educational needs, but can you give us some further insights on how those educational needs can be linked to educational outcomes?
Thank you, Froukje. Yes, as you said, every educational program needs to start with a needs assessment. And if I take that further, it's got to start with identifying the gap in patient care, i.e., why are we even trying to educate the healthcare professional in the first place? What do they need to do? What does the healthcare professional need to do better to better care for their patient? And once you've identified that thing that they need to, that the healthcare professional needs to do better, then your outcome is to educate the physician to implement that thing. It could be knowledge gain, it could be a skill, it could be motivation or attitude. But that's how we link the educational outcomes to the needs assessment.
Thanks, Sophie. Now, and you already touched upon it a little bit, the higher levels of outcomes, so level 6 or 7, and Monica with the AO Foundation and the work you do there, I think you're very well placed to assess those higher levels of outcomes. What do you see as feasible in getting to those levels 6 or 7?
I mean, as you say, I mean, patient health and community health is really, really difficult to measure. As I mentioned before, also the performance, if you want really to follow directly the learner, is difficult because you have really to go into the hospital and look there what they are doing. But let's say that what you can do on the patient level is probably if you are in a hospital, you can look at the database that you have available there, and if the general health of the patient is improving over time. And also on the state level, you can have the database and look and analyze those data. But can you link that to a single educational event? Then this requires really more effort. I mean, probably Sophie will give you also another example later on, but at least what we have done is we want to try to link education to improve performance and also to improve patient care. But to do that, so the goal is really for a specific type of surgery, follow up the patient after the surgeons have done the course that we are providing. But to do that, really, it's a clinical trial. So we have multiple steps. First of all, you have to describe, do you need a tool to measure the performance? And we are in a global environment, so already to, every country does a little bit different. So already to agree on a unique tool to measure the performance of a surgeon, it took 2 years, and validate that. Now we have this tool and we can use that to evaluate the performance. And another trial, a clinical trial, is then after the performance, can we link the performance to the improved, we want a reduced mortality rate. So the final readout is kind of easy to see, but still the whole process is very long and yes, really time consuming. And I mean, if you want to do it, you need to do it properly, but you cannot do this for every single course that you do. I mean, it will be impossible to realize. Yeah. And for the community health, we have also another project that is basically a case registry. Compared to other registries where you have databases from patient, what we are inserting is also the patient-reported outcome. Because we feel that sometimes, let's say the databases report only certain type of readouts from the hospital and from the surgeons. But in many cases, the patient is not having what they were expecting as an outcome. They want to go back to their normal life, but maybe still affected. So this is what we are trying to do. And on a general level, basically.
Thanks, Monica. Very clear. And again, good to be realistic on the feasibility of that. So now let's switch gears a little bit. Sophie, also in our world of independent medical education, there's an increasing role for social media. What are your thoughts on measuring outcomes for educational programs delivered through social media?
Thank you, Froukje. I'm going to be really honest. I think social media is potentially a really powerful educational tool, but I'm not sure we know yet how to use it in the most effective way for pure education. I mean, I think we've probably all used social media to promote a program, to raise awareness, to get engagement. But the question is, how on earth do you educate in 280 characters? And if anybody's found a solution, I'd love to know. So what can we do beyond promotion? I think social media is a great tool for stimulating discussion. Okay, that's not formal learning, but it's reflective learning. It's immediate, it's fun. You're talking with your peers. You're definitely learning if you're doing that. People like to talk to their peers, so there's a lot of engagement as well. So I think we shouldn't undervalue that reflective learning. Now, in Europe, and I know in the US it's different, but in Europe, accredited learning is still generally, although it's changing, tied to 1 hour of learning. But microlearning is on the increase. The accreditation organizations are definitely changing and adapting to this new environment. So microlearning is on the increase. And so we should start to explore microlearning platforms as a way to share small pieces of content, infographics, short videos, and stimulate that reflective learning. And we can probably start using polling tools on the platform. You know, you can also link out from a social media platform and link out to a video, but also link out to an online test, an online evaluation. So I think it will be possible. I think we still need to explore how we do that more formal education. The challenge is also going to be to promote your program and get enough followers to stimulate meaningful discussion and learning. But definitely something to keep an eye on and very exciting.
It is exciting. Eh? Thanks, Sophie. Thank you. Monica, maybe a question came in on the topic you described just now about the the educational intervention and your clinical trial. A question came in on how long the intervention was, and if possible, if you could explain the intervention in a little bit more detail.
So basically, normally the intervention that we are talking about is a 2-day workshop that has, let's say, lectures. So it has a knowledge component and a skill component. So we really go into, since it's a surgical procedure, they need to be able to perform it. So we go through the steps, how it's performed. So it's normally 2 days. Yes.
Okay, thank you. Then there are a number of questions about level 5, so performance and level 5 performance and gauging the impact of CDP in the clinic. Sophie, could you talk a little bit more about that?
Yes, I mean, I think Monica has already talked about the challenges of assessing and the reality of assessing level 5 outcomes. I mean, as a reminder, level 5 is about implementing it, what you have learned in your day-to-day. So outside of the educational setting. And that's always a challenge, because once your learners have gone back to their clinic, they're invisible to you. They've left school. I mean, how do you see what they're doing? So that is a challenge. Monica suggested one way to create a meaningful assessment of outcomes is to do some follow-up after the educational intervention. So reach out to them, get them back to that school reunion. I think key is to make sure that your program is set up to educate on something that can actually be implemented by the physician in their daily practice. You know, it might be an injection technique, it might be knowledge of new treatment guidelines. But if it's something they can actually use, then to gauge the outcome, you can ask learners to submit anonymized data. For example, you can say, okay, when you go back to your clinic, please use this form to submit data on the next 10 patients you see, or something like that. And then you ask them 3 months later, 6 months later, to submit the same data on the same patients in the follow-up. And then you can see, by looking at those submissions, you can see whether or not they've changed how they treat their patients in practice. You can, and I know in the States they do that, as an incentive, you could consider this as an add-on micro-learning module, reflective learning, so that they can get further credits.
Yeah.
So that's one way of doing it.
Yeah, or the self-reporting, as
Yes.
Monica already explained, which is maybe not optimal, but it could suffice. Let's see, we have 4 minutes left. Let's go to a question that just came in. It's about the pyramid, the Moore scale. How would you update it? This is actually a question that also came in through the registration, that it's effectively aligned with what's clinically realistic to see a result of your education. So do you think the pyramid of Moore's, of the the educational levels, if that should be changed or revised or updated?
I'm not sure it needs to be. I think it's an important pyramid, because I think what it shows us is that there are different levels of education, and there's different. And you need to do different things in the clinic. There's some things you can do in an educational setting, and there's some things that need to be done in the clinic. And I think the pyramid distinguishes that really nicely. And I think it's really, really important that providers, learners, but also supporters understand this, because we've all come across a request for a proposal where it says, can we have levels 5, 6, or 7? And then it's got to be realistic. And I think, so I like the pyramid because it makes those distinctions really clear. Then how you apply it in different settings. You know, Monica, they have surgery and simulations and practical workshops. You'll look at it in a slightly different way to if you're doing online learning, or if you're doing a motivational interview workshop. So I'm not sure it's got to change, because I think it holds the basic concepts and is really clear. I think what's important from the pyramid is to know that CPD isn't just about 6 and 7. There are levels 1, 2, 3, 4, and 5 underneath. And there's a need for education at every single level. You know, if a new treatment comes along, you don't need level 6, 7. You need level 3. People need to learn the new guidelines, the new mechanisms of action, learn how about this product so that they can apply it and use it effectively in their clinic. They don't need level 6, 7. They need a good level, solid level 3. So for me, that's what the pyramid does. It shows us really clearly that there's different things to aim at, and we shouldn't be.
Thanks, Sophie. We have 1 minute left. Monica, is there anything you would like to add to this on the pyramid? I think it was a clear message from Sophie, but anything you would like to add?
It's good to have it there as a, let's say, to reflect and but be realistic in where you can position yourself.
I think that was clear. Excellent, thank you. There have been more questions submitted. What we will do as a gCMEp practice group is we'll look at those also with other questions that had already been submitted and consider doing a second webinar on educational outcomes. The need for this was high. I would like to thank Monica and Sophie for your insights, much appreciated. Thank you all for attending and submitting your questions. We'll follow up. This is clearly an area of high interest for all of us, but we're also very keen to receive your feedback on this webinar. I would also like to ask everyone to keep an eye out for the gCMEp practice group activities. The recording of this webinar will be posted on the website. There are other recordings already there, all linked to the CME environment in Europe. And also announcements for future webinars will come up there. So thank you all again. We're on the 30 minutes. It was a pleasure. Thanks again, Sophie and Monica, and see you all next time. Thank you. Bye.
Bye.